My name is Mandy Rickard, and I am a nurse practitioner with the Division of Urology at the Hospital for Sick Children in Toronto, Ontario, Canada. Today I will be presenting our work about using deep learning to predict renal outcomes solely based on kidney ultrasound images. I would like to take a moment to acknowledge that while we are all disappointed to have missed out on our opportunity to meet in person in beautiful Bermuda, we are appreciative of the opportunity to present our work in this virtual venue. The objectives of our talk is to provide an overview of hydronephrosis, to describe the development of our model, to discuss model accuracy and our prospective testing to date, and to talk a little bit about future directions for this work. Hydronephrosis refers to the accumulation of urine in the kidneys and/or ureters. It is the most common congenital anomaly detected prenatally and occurs in up to 1 to 5% of pregnancies. Because it is so common, it represents upwards of 15 to 30% of our clinic volumes for close postnatal monitoring. As most of you know, hydronephrosis is not an illness or a disease, but a finding on ultrasound. When we consider the causes of hydronephrosis, it is important to note that approximately 80% of hydronephrosis is transient and self-resolving. However, some hydronephrosis might be due to obstructions or to reflux, which is the retrograde flow of urine from the bladder to the kidneys. Because the etiology of hydronephrosis is not always clear up front, it is beneficial to consider the goals of management. While this slide highlights many possible management goals, the goals driving this project are early identification of surgical patients and minimizing invasiveness of monitoring. Despite a good understanding of management goals, deciding between surgical intervention and monitoring remains a common challenge and controversial topic within the pediatric urology subspecialty. Identifying those patients who would benefit from surgery is not always possible upfront or with early ultrasound images. There are expertise-based guidelines available that can help us guide our decision-making for hydronephrosis. This one is from the 2018 Canadian Urological Association Guideline on Antenatal Hydronephrosis. This flow diagram separates hydronephrosis by severity of dilatation, and depending on their clinical trajectory, the patient receives at least one future ultrasound, and many will undergo a VCUG or a LASIK scan. However, as you can see, this flow diagram is quite complex with many deviations, and it was developed based on limited evidence and expert opinion. We put our patients through these diagnostic tests to provide information to help us decide who might benefit from a surgical intervention. Indications for surgery from the 2018 CUA guideline are listed here. While this list is quite comprehensive and includes many of our indications for surgery at sick kids, many of these points remain debatable and inconsistent between centers and surgeons. After reviewing those guidelines, I wanted to show you what the current management of hydronephrosis patients looks like at our institution. Hydronephrosis is detected prenatally and is followed postnatally with serial ultrasounds. Depending on the appearance of hydronephrosis or the development of symptoms such as UTIs, patients may undergo invasive tests like VCUG or nuclear scans, and at some point, they may undergo a surgical intervention. From our data, less than half of patients who are investigated with the nuclear scan ultimately undergo surgery. So is there a better way to identify which patients would benefit from surgery without investigating most of them with nuclear scans? Due to the invasiveness of hydronephrosis monitoring and the large number of children investigating with these tests, risk stratification by ultrasound images is very appealing. So what do we already know about ultrasounds? This slide highlights some of the limitations and advantages of ultrasounds, with the main advantages being that ultrasound are non-invasive, well tolerated, and widely available with no exposure to radiation. So given these advantages, there is value in exploring if we can extract more information from these images. Our hypothesis is that there is information embedded in ultrasound images that can be used to predict outcomes, and that this can be optimized with artificial intelligence. This project is taking place at an appropriate time. At our institution, a key component of the strategic plan for sick kids is to optimize artificial intelligence technology in order to improve personalized patient care. We are hoping to contribute to this vision through the work we are presenting to you today. We selected children who are less than 2 years of age at baseline, and we included isolated hydronephrosis, megaureters, and hydronephrosis associated with reflux. All SFU grades were included. This left us with 294 patients who met our criteria. We used their ultrasound images, which contained over 1,300 images, and built a convolutional neural network to automatically assess image features, with the goal of predicting the likelihood of obstruction, presence of reflux, and an estimate of differential function. The data was split into 70% for training and 30% for validation. We use one sagittal and one transverse view image from right and left kidneys to predict the likelihood of obstruction, using surgery as a surrogate, the presence of reflux, and an estimate of renal function. Images are passed through each layer, and a report for the likelihood of outcomes of interest is produced. Our model is a convolutional neural network with 7 layers. It is a Siamese model, which is used because we wanted to include 2 ultrasound views for predictions with the same filters for each image. After the image has been passed through all 7 layers and we have our result, it is flattened in order for it to be combined with the additional views. Concatenation allows the data from both views to be combined into a single report, and this is repeated for both left and right kidneys. We compared our model, a custom 7-layer CNN with 2 fully connected layers, to VGG16, DenseNet, and ResNet. We also compared using single views versus combined views, and we noted that the Siamese views perform better, particularly with reflux and function. Our obstruction model was the first model we developed, hence the accuracy with an AUROC of 0.93 and an AUPRC of 0.74. VUR and function are newer models, and in preliminary testing are performing modestly well. So I'm sure most of you are familiar with the black box effect. This refers to the uncertainty with what is happening in the hidden layers of a model. We see what goes into the model and we see what comes out, but we have no idea how this output is generated. This may result in apprehension in trusting the predictions generated by a model. Ensuring explainability and transparency in algorithm predictions is important, especially for those that may influence healthcare decision-making and patient care. So how do we know that we can trust our model? One way we improved explainability and attempted to mitigate the black box effect is by generating heat maps or GradCams to overlay on the images. And as we can see from this example, the areas in yellow are those deemed the most important in making the prediction and are in keeping with the same areas we as clinicians would look at to assess hydronephrosis severity, such as the hydronephrosis area and parenchymal characteristics, which drive the decisions for further investigations or indicating a surgical intervention. Previously, we reported that less than half of patients who underwent invasive testing actually went on to surgery. This is where we see our model having the greatest impact on clinical practice. Our model has the potential to impact practice by allowing monitoring by ultrasound alone for those patients who are low risk of surgery and expediting surgery for patients most likely to benefit from it, all while minimizing the need for invasive testing. So now that we seem to have a working model, what's next? Our institution has recently developed an AI-specific panel for reviewing all AI-related research studies being proposed at SickKids. It consists of these 3 steps. The sandbox refers to the development of an imaging repository for exploration and development of a model. We used a renal imaging repository in our project. Step 2 is a silent trial where the algorithm is being tested prospectively, behind the scenes, if you will, in a clinical environment but has no impact on patient care, followed finally by a clinical trial. We have just recently completed step 2. We conducted our silent trial to establish safety of the model in determining which patients could be safely discharged. We have established a false negative rate of 6.7%, which means we can safely identify patients which can be discharged with no further follow-up or additional testing required. We're also fortunate to have set up collaborations with many hospitals across North America. This is extremely important because although our model performs well for predicting at our institution, we need to reduce the risk of overfitting and biases by assessing how it functions in other settings. The next phase is to use the ultrasound images and some limited clinical data from these sites and run it through our model with the predictions being sent back to that institution. In conclusion, prediction of surgery for hydronephrosis, the presence of reflux, and a function estimate based on ultrasound images alone appears to be feasible. Our classifier accurately discriminates between surgical and non-surgical, refluxing and non-refluxing kidneys without feature engineering or clinical patient variables from baseline or early ultrasounds. This technology may allow for a dramatic decrease in invasive testing for infants with hydronephrosis and more efficient access to surgery for those who will benefit from that intervention. I would like to thank you for the opportunity to highlight our work and invite you to contact me with any questions or comments. Thank you.